Good morning, good afternoon, and good evening. Thank you for joining the Health Effects Institute for the final webinar in our 2021 conference series. My name is Eliane Van Vliet, and I'm a staff scientist at HEI. I'd like to acknowledge Dan Kraus, Senior Consulting Scientist at HEI, who co-organized today's session, as well as all the staff who worked behind the scenes to put this webinar series together. Before we delve into today's webinar, I'd like to make a few housekeeping announcements. All attendees are muted for the duration of the webinar, and questions will be reserved for the 25-minute Q&A and discussion at the end. You can submit your questions using the Q&A function at any time during the webinar, and you can also upvote questions in the Q&A function. Please contact us in the chat box if you experience any logistical issues. And in case you've missed any of our 7 previous webinars, all recordings will be available on our website within the next few weeks, and you can find the links to the recordings and slides there. And finally, to help us improve the webinars, please complete the post-webinar feedback survey, which will be emailed to you tomorrow. So today's webinar will focus on what has been learned about the health effects of long-term exposures to low levels of air pollution. Results will be presented from 3 HEI-funded studies conducted in large populations across the United States, Canada, and Europe. We have an interesting session for you today, and to lead our way through, it's my honor to introduce today's session chairs. Dr. Amy Herring, who is a Sarah and Charles Ayers Professor of Statistical Science and Global Health at Duke University and a member of HEI's Research Committee. And Dr. Sverre Vidal, Professor Emeritus in the Department of Environmental and Occupational Health Sciences at the University of Washington School of Public Health. He's also the chair of the HEI's Low Exposure Epidemiology Studies Review Panel. I will now hand over the mic to Dr. Herring, who will introduce the speakers.
Thank you so much. It's very good to see you today, and I appreciate your joining. If we can go to the next slide. Today's session will feature Robert O'Keefe from HEI, Dr. Danielle Braun of Harvard University, Dr. Tanya Christidis of Statistics Canada, Dr. Jay Chen of Utrecht University, and Dr. Sverre Vidal from the HEI Review Panel. As mentioned, you'll hear from these 3 speakers from the study teams. We'll hear commentary from Dr. Vidal on behalf of the review, and then we'll take questions from the audience. First, Bob O'Keefe will introduce the session and give some background on the set of studies funded by HEI to explore potential health effects at low levels of exposures. Bob O'Keefe has served as Vice President of HEI for over 2 decades. He provides leadership for the Institute's major programs, including CORE, Global, and Energy, and leads the Institute's engagement with the U.S. Congress and other domestic and international regulatory bodies. Prior to HEI, he served as Assistant Deputy Commissioner for Policy and Programs at the Massachusetts Department of Environmental Protection. He's currently a member of the US EPA Mobile Sources Technical Review Subcommittee and Chair Emeritus of the Board of Clean Air Asia. I'd like to welcome Bob now.
Thank you very much, Amy. That was great. Appreciate your introduction. My slides are clear?
They look good.
Great, thanks. The studies, oops. Let's see, these aren't advancing correctly. Let's see, there we go. Let me try again. I may need you to hop in here. I'm having a little trouble with the slides, but let me try one more time. No, my advancing is not working for some reason. Are you able to advance my slides? Let me try one more thing. Nope, it's frozen. Are you able to advance my slides for me, please?
I'll have to stop sharing, Bob, then I can share.
Yeah, please do.
Okay. If you can just stop sharing at the top.
Yep.
That'd be great. Thank you.
Yep. Thanks so much, Elian. If you could go to slide 2, and I apologize for that. Good morning from Boston, everyone. The studies you'll hear about today originated from HEI RFA 14-3. The overall objectives of the RFA were to fund studies to assess the health effects of exposure to low levels of ambient air pollution on all-cause and cause-specific mortality and morbidity. Also, exposure response functions for PM2.5 and other pollutants at low levels, and to identify and develop statistical and other methodologies, including new and improved exposure surfaces and estimates in a couple of the studies. Slide, please. The motivation for HEI's low exposure studies recognize that despite significant advances in air pollution in recent decades, primarily in high income countries, several large epidemiological studies in 2012 found associations between PM2.5 and mortality below the then current standards. With both ongoing and expected future reviews of national standards and guidelines by US EPA and EU and the WHO, among others, HEI undertook these studies to inform risk assessment and regulatory decisions to help confirm whether adverse health effects continued at or below the current standards. The graph on the left depicts a steady decline in PM2.5 levels that was observed in the US from 2000 to 2017. And the graph on the right illustrates the concentration response function from the Canadian study, extending below the US and WHO standards and guidelines. Slide, please. So what are the policy relevant questions these studies seek to help answer? First, a better understanding of concentration response relationships helps understand the shape of the relationship at very low and very high levels. For example, is there a threshold? And if so, at what level? It also helps assess whether a particular exposure may cause a specific effect, and ultimately estimates the public health burdens from an exposure. These in turn provide a basis for at least two important policy questions. At what level should we set ambient air quality standards, and to what level of exposure should we estimate public health impacts? Slide, please. These studies, when completed and reviewed, which they're close to being, are expected to contribute significantly by harnessing exceptionally large data sets to estimate exposure at very low levels, considering potential confounders to the maximum extent possible, and applying a range of analytic approaches to test sensitivity to model selection and possible causal inference. Slide. The three studies you'll hear about today were selected competitively, as are all HEI studies, and have several common and many unique features. Populations with millions in the United States, Canada, and Europe in both administrative and traditional cohorts. They relied on satellite data and ground level exposure measurements and high quality exposure assessments and models at high spatial resolutions. They also focused on development and application of the novel statistical methods needed to conduct analyses in data sets of this scale. This is a map that'll be familiar to many of you. It shows locations of the three studies, obviously. First, the ELAPSE study by Bert Brunekreef, conducted in University of Utrecht in the Netherlands, focuses on, was titled Mortality and Morbidity Effects of Long-Term Exposure to PM2.5, black carbon, NO2, and ozone. It was an analysis of European cohorts, including 28 million Europeans in pooled data from the 10 escape cohorts and 6 large administrative cohorts. The Harvard study in the US, led by Francesca Dominici, assessed adverse health effects of long-term exposure to low levels of ambient pollution and focused on mortality and morbidity. They had a total of about 60 million participants in America, including 28.6 elderly Medicare enrollees, 28 million Medicaid employees, and an additional 15,000 subjects from the Medicare beneficiary survey with individual level risk factor data. The pollutants included PM2.5, NO2, and ozone again. The MAPLE study, led by Michael Brower in Canada, he was from the University of British Columbia, focused on mortality, air pollution exposures in low-income environments. And it included 8.5 million Canadians using Canadian National Census data and an additional 540,000 participants in a Canadian community health survey with more individual level data. The participants, the pollutant studied there included PM2.5, NO2, and ozone. And as mentioned earlier, to assess exposure, the teams used hybrid exposure models, including satellite data, incorporating satellite data, chemical transport models, routinely collected monitoring data validated, and land use and other variables. Slide, please. All of these studies were subject to the HEI oversight and quality that we're all quite familiar with, beginning with an oversight committee chaired by John Samet from the from Colorado School of Public Health. And the teams were required to submit biannual progress reports, participate in webinars and meetings with the public and sometimes with sponsors, and were subject to rigorous QA/QC audits. As you'll hear, we impaneled a low exposure review panel chaired by Sverre Vidal, who you just met from the University of Washington, and will speak a little bit later. The panel is conducting detailed peer review and will provide a commentary for each study. The results today include initial findings for the United States and Canada that were published after review in November 2019, and this was to inform ongoing regulatory decision-making that was occurring at the time, including at US EPA. The final comprehensive results are currently in peer review and will be published with commentaries later this year. Because of the rich data sets that these studies generated, HEI is now funding additional individual and joint level analyses to further test the results. These include harmonized analysis across all three populations, additional causal analysis, and probing of relationships of multiple pollutants, shape, and covariates. Slide. These are the teams. You can't read these, but these slides will be on our website of remarkable scientists who conducted this work from around the world. And I will say that we're quite privileged today to have most, if not all, of the PIs available. Bert and Michael and Francesca are available to answer questions along with the presenters when we get to the Q&A portion of today's session. So thank you very much.
Thanks very much, Bob. So now we'll start with our first lead-off speaker, Dr. Danielle Braun. Danielle is Senior Research Scientist in the Biostatistics Department at the Harvard T.H. Chan School of Public Health and at the Department of Data Science at Dana-Farber Cancer Institute. Her areas of research include causal inference, measurement error, environmental health, risk prediction, genetic epidemiology, survival analysis, frailty models, clinical tool development, and comparative effectiveness research. Today, she'll make comparisons across studies with a focus on confounder control and causal modeling. Let's welcome Danielle.
Thank you, Amy. So I'm glad to be here. I'm going to be presenting today, as Amy just said, on the effect of confounder control and causal modeling across the three different studies. As Bob mentioned, some of this work has been previously published and some of it is part of the team's HEI final reports. So just to introduce kind of the context. So all the three studies assess the health effects of long-term exposure to low levels of ambient air pollution, PM 2.5. So ideally, you would randomize patients to low or high air pollution, but that's not feasible. So all three studies actually relied on our observational studies. They relied on claims data to do the analysis, but claims data have limitations due to the lack of randomization. So there are factors that may be associated with both exposures and the health outcome, like socioeconomic status, that may actually confound the exposure comparisons. So the challenges that we're going to talk about today. So there are some challenges due to unmeasured confounders. Individual level covariates may confound the exposure comparisons. Some individual level covariates were missing across all three studies, just because, again, the studies relied on claims data. But each team approached this and tried to overcome this challenge in a slightly different way, and we'll talk through what each team did. And then the second topic is how to adjust for measured confounders. And so oftentimes these confounders are included as linear terms in statistical models, but this could be actually sensitive to model misspecification. So we'll talk a bit about causal inference approaches that help, that are a bit more robust to the model misspecification. Okay, sorry, my slides aren't advancing. Okay. So the first study that I'm going to talk about is the MAPLE study. The MAPLE study relied on two different cohorts. The first is the Canadian Census Health and Environmental Cohort, CanCheck. These are three census-based cohorts in 3 different years. They had 7.1 million respondents and 128 million person years. And so for this cohort, they had some individual level data and some contextual level data like community size and neighborhood marginalization. And then they had actually a second, more detailed data set from the Canadian Community Health Survey, CCHS. And so that data set actually had additional information about health behavior. So that had information on smoking, on alcohol consumption, BMI, and other variables. The inclusion was individuals who are greater than 25 years old. They were censored at 89. And then the outcome that I'm going to be talking actually throughout this talk today, we're just focusing on mortality. So they looked at non-accidental mortality. So the first thing that we're going to go over is different covariate, different ways, different covariates included in the outcome model that the MAPLE study considered. So they actually looked at 3 different models, and each one kind of with a varying level of covariates included. So the first, and they did this both in the CAN-CHEC cohort and the CCHS. And again, we're looking at the relationship between PM2.5 and non-accidental mortality. And so the first model is an unadjusted model. It doesn't include individual level covariates. And then the second model is adding individual level covariates and then adding contextual covariates. So that's the data that's available in CAN-CHEC. So we see here that the hazard ratios are still significant as we add more covariates. They're still statistically significant with a hazard ratio of 1.084. And then for the CCHS, in addition to the comparison of the individual level covariates and the contextual covariates, where you can see again that the hazard ratio is significant, they added the behavioral covariates that were available in this cohort and still results in a significant hazard ratio. These hazard ratio estimates are per 10 micrograms per meter cubed. So the other thing that the MAPLE study did was they did an indirect adjustment for the missing behavioral covariates in the CAN-CHEC cohort. So they used indirect adjustment via partition regression to adjust for the unmeasured covariates. So the method actually uses a representative ancillary data set to estimate the associations between the missing variables in the primary data set. So that's the BMI and the smoking, for example, and the other behavioral variables. And then they are able to leverage the complete set of covariates that's in the ancillary data set. So that's the CCHS data set that has all these individual level factors. And so they're able to then produce an adjusted risk estimate for the variables in question here for the, and they were able to adjust the hazard ratios for the association between PM2.5 and mortality. So they did this, and again, their main study was the CAN-CHEC study. They used the 2001 CAN-CHEC study as the primary data set. And then they were able to leverage the 2001 CCHS as the ancillary matching data set that actually contained the information like smoking and BMI that wasn't available in the main data set. So the results are published in a study in 2019. So we see here the hazard ratios. These are again per 10 micrograms per meter cubed increase in PM2.5. They explored 2 different models. So model 1 includes individual covariates, and the model 2 includes the individual and contextual covariates. And then they they report the unadjusted and adjusted estimates both in the CAN-CHEC cohort, which are these, the first row and the third row here, and then in the CCHS study. So we see here actually that the results from the CCHS analysis, both from the CCHS analysis alone and the indirect adjustment, so we can see the adjusted compared to the unadjusted, they only suggest that these behavioral covariates only slightly confound the PM2.5 mortality association. So they concluded that missing data on the behavioral covariates was unlikely to significantly confound the associations in these studies. And again, you can see that the hazard ratios do change slightly, but are still statistically significant. So I'm going to transition and talk about the ELAPSE study and how they handled this issue. So the ELAPSE study, as Bob mentioned, so I'm going to focus on results from large administrative cohorts from 7 countries in Europe. That includes over 28 million people. The inclusion criteria was 30 years old or older at baseline. And again, they looked at non-accidental mortality. So in terms of covariate adjustment, they also consider different models with varying level of adjustment. So to, again, evaluate the associations between PM 2.5 and non-accidental mortality. Their first model included only age, sex, and calendar years. And then they added individual level variables that were available within each cohort as model 2. And then model 3 adds to model 2 the socioeconomic status and other variables. So the results from the comparison of the 3 models are presented here. Please note that the hazard ratios here are now per 5 micrograms per meter cube increase in PM 2.5. And this is the results are presented for each cohort. And so we see here that actually in all the cohort, as we go from model 1 to model 3, we do see some changes in the hazard ratios. It's interesting that for some cohorts, actually, the hazard ratios are increasing as you add more and more covariates into the model. And for others, we actually see a decrease in the hazard ratios, for example, in the Dutch and the English cohort. So ELAPSE also did the indirect adjustment method to try to adjust for the unmeasured potential behavioral confounders like smoking status and BMI. And so they applied actually the same method by Shin et al. And they were again looking at natural cause mortality and PM 2.5. So they were able to leverage as their ancillary data set, they were able to leverage actually surveys on variables like smoking, alcohol use, and BMI. So they were able to leverage that in these countries in the Netherlands, Switzerland, Norway, Belgium, and Denmark. The English cohort actually already had individual level data on smoking and BMI, so there was no need to actually do the indirect adjustment on that in that cohort. So in terms of the results, so we see here that in some of the countries, so these are the results by country, this is for PM 2.5, we see the hazard ratio in the main model, and then we see the hazard ratio with the indirect adjustment. And again, their hazard ratios are per 5 micrograms per meter cubed increase in PM 2.5. And so for some countries like the Dutch, the Swiss, the Norwegians, the hazard ratios were actually attenuated, but they still remained mostly significant. I think there was one borderline in the Dutch cohort. And then in the Rome and Belgium, the hazard ratios actually increased after the indirect adjustment. So the third study is the Harvard study using the Medicare data set. So we had data from Medicare, which is a national health program for individuals over 65 in the US. We have over 68.5 million observations. We looked at all-cause mortality. So compared to the other 2 studies, we had data on all-cause mortality. So the first set of results that I'm going to present are how we approach this covariate adjustment. So the Medicare data actually contained very little information about the individual level covariates, but we were able to actually obtain more detailed information for a subset of individuals that are enrolled in the Medicare current beneficiary survey, the MCBS. And so this is an annual phone survey. It's meant to be nationally representative of Medicare beneficiaries. We had information on more than 150 potential individual confounders and risk factors. And so we analyzed the data for this cohort of 32,000 beneficiaries. So in terms of the results here that were presented in this publication actually compare the hazard ratios using all variables to those that are available in Medicare only. These hazard ratios are actually attributable to an increase in long-term average PM 2.5 from less than 12 to greater than 12 for the full cohort, and 8 was used as a cutoff. So actually the exposure here was dichotomized to be a binary exposure. And we see here that actually in terms of the covariates, we see very similar hazard ratios in the low pollution cohort. And in the full cohort, we do see slight differences, but the confidence intervals are overlapping. So the last topic of this presentation is actually going to focus on causal inference adjustment for measurement confounders. and the work that we've done in the Harvard Medicare cohort on this. So causal inference methods are designed to really bridge the gap between the observational studies and randomized experiments. They're more robust to model misspecification. So we actually applied various traditional and causal inference approaches, and we conducted quite extensive sensitivity analysis. We relied on publicly available data, and we provide the code in the GitHub. So you're welcome to actually go to the GitHub and download that code, use it. In terms of the results, and this is published in 2020, we see actually, so on the left here is our hazard ratios. This is per 10 micrograms per meter cubed increase in PM. We're looking again at all-cause mortality. This on the left is the entire cohort. And so we compare different approaches, a Cox model, a Poisson model, and then 3 causal inference approaches of matching, weighting, or adjustment using the generalized propensity score as a covariate in the model. And we see that the hazard ratios are actually quite robust and with overlapping confidence intervals. And then on the right, we actually focus on Medicare enrollees exposed to low air pollution, less than 12 micrograms per meter cubed. And we see here that the matching, weighting, and the adjustment are actually slightly lower, but still very much statistically significant hazard ratios compared to the Cox and Poisson model regressions. So one advantage of the causal modeling is it allows us to kind of assess the quality of the causal inference approaches that we're covering the randomized experiments. And one way to do that is to look at and evaluate covariate balance for each confounder. And so the idea is that we have here the absolute correlation between PM and each of the potential confounders. And we have the unadjusted absolute correlation. And then after you match in green or weigh in blue, we're able to create a pseudopopulation. And once again, on that pseudopopulation, evaluate the absolute correlation. And so ideally, a good causal inference approach creates a pseudopopulation that would have an absolute correlation here of less than 0.1 for all the covariates. And we see that actually, indeed, like for the matching is able to achieve that for almost all of the covariates, and even weighting does quite well. So this kind of gives us a sense that we were able to create a pseudopopulation that's meant to mimic, again, the randomized control study. So just to conclude, so all 3 studies had some missing data on the behavioral covariates. They're unlikely to significantly confound the PM mortality relationship. In the Medicare cohort, we used the 5 different approaches, and all of those led to similar hazard ratio, which is great and shows that kind of the estimates are robust. We provide the GitHub code, so these estimates are reproducible and really provide evidence on the causal link between PM and mortality. So in terms of ongoing work, so as Bob mentioned, like all 3 teams are working on harmonizing the analysis. We're working on harmonizing confounders and models across the data set. And then in addition, the ELAPSE and the MAPLE team are actually working on applying the causal inference approaches that I described today. And just acknowledgement, so as you all know, so this work was funded by the Health Effects Institute. So thank you.
Thanks so much, Danielle. We really appreciate such a clear and informative presentation. I see a couple of questions already in the Q&A. Please keep those coming and we'll address them in our discussion time at the end of all the presentations. So today's next speaker I'm happy to introduce is Dr. Tanya Chrysidis. She works as a research analyst at Statistics Canada's Health Analysis Division in Ottawa. She's worked extensively with the cohorts that are used in the MAPLE project, including in data validation, knowledge translation, and the creation and analysis of environmental exposure cohorts to examine the relationship between a variety of different outcomes and exposures. Her PhD research examined risk perceptions and health impacts related to wind turbines, and she previously worked as a student researcher at the Public Health Agency of Canada, exploring risks related to foodborne, environmental, and zoonotic infectious diseases. Today, she will share work comparing different concentration response functions in these studies. And now I'll turn it over to you.
Hi, I see a bit of a lag, so I'm just going to wait until I see someone that's not Amy in that little corner, but maybe that's just what it's like.
I can
Amy,
see
can
you
you
and
see
the
me?
slides. Yeah, I can see you and the slides.
Okay. Well, I'll just stare at your face then. So thanks for that introduction. So in this presentation, I will be discussing the relationship between exposure and outcome and how it's been modeled in these 3 studies. I will go through the linear models, the concentration response functions, and then briefly how these relationships exist at the lowest exposure levels. Next slide. So first things first, what do linear models tell us? So in the chart, you'll see the results of the most comparable linear models between our 3 projects. These are the fully adjusted models from our administrative cohorts with varying classifications of mortality. And I've also included the person years. You'll see that the ELAPSE cohort had the highest hazard ratio at 1.109, followed by MAPLE at 1.084 and Medicare at 1.066. So these hazard ratios indicate anywhere from a 6 to 11% increased risk of mortality from exposure to PM2.5 per 10 micrograms per meters cubed. And it's worth noting that these results are broadly similar, and you can see that the confidence intervals overlap. Next slide. So linear models are limited in that they assume the same relationship between PM2.5 and mortality at all levels of PM2.5 exposure. The same is true for confounders, which are assumed to impact the relationship between PM2.5 uniformly at all levels. And linear models do not provide insight into a threshold at which exposure does not lead to mortality. Next slide. So therefore, in addition to linear models, we plot the concentration response functions so that we can allow for different relationships between PM2.5 and mortality at different levels of exposure. So if you look at this graphic that I've included, you can see that you can establish some points or knots with your data and then connect them in a variety of different ways. And so the method that you choose to connect those dots has an impact on the predicted values between those knots, as you can see in these 3 plots. So for example, a cubic spline allows for each pair of knots to be connected by a different shape or curve, which allows for a different relationship at different levels of PM. And the smoothness or curvature of this shape can be controlled by the number and placement of knots and or a smoothing parameter. Next slide. There are some limitations of cubic splines. This is an example from the MAPLE work, and we produced restricted cubic splines ranging from 3 to 18 knots. And you can see as we move along, the curves become more wiggly. The red one is the best fitting spline that I'll discuss later. So the challenge that we find is to find a flexible curve that best represents our data, but that also to keep in mind that a wiggly spline may be a better fit, but is not necessarily useful for risk assessment. Next slide. So in the ELAPSE study, they used a natural spline and examined natural cause mortality. They decided to investigate 1 to 3 knots a priori, and I'm showing their preferred plot here, which used 2 knots. The red dotted lines indicate air quality guidelines, and the histogram is the distribution of exposures within their cohorts. So you can see that the spline is linear below the lowest and above the highest knot concentrations, and there are no wiggles. You can also see that there is no low-level threshold for the mean predictions and a flattening of the curve at higher concentrations. Next slide. In MAPLE, we used a restricted cubic spline, and here I'm showing the spline for non-accidental mortality. We selected the best fitting restricted cubic spline by using a controlled search between 3 and 18 knots, which I showed before. And we found that the best fitting spline was 9 knots. And you can see that it's wiggly between 5 and 12 micrograms per meters cubed. The lower confidence interval is above 1, starting at 2.9 micrograms per meters cubed, which is close to a minimum of 2.5 micrograms per meters cubed. And this result was insensitive to the number of knots that we included. Next slide. In the Medicare study, they fit their curve within a causal inference framework with one kernel equivalent to, a not or person for each point. So this curve is for all-cause mortality. What we see is there are gradual changes in the curvature with an increase at the low concentrations, a bit of a flattening, a little bit of an increase again, and then a flattening again. Their curve is almost linear at levels lower than current standards, and they controlled their curvature with smoothing parameters. Next slide. So why do we smooth the curvature? As I said previously, you have to remove the wiggles and extreme curvature in order to create a curve that is meaningful for risk assessment. In ELAPSE and MAPLE, we used a different approach to smooth and control the curvature. ELAPSE used the shape-constrained health impact function, which we call the SHIF. This creates a family of plausible sigmoidal shapes to fit the data. Curvature is controlled by limiting the range of parameters. And then the model is a weighted average by log likelihood of all of the shapes examined. Next slide. So here I have shown the ELAPSE spline again to the left and the SHIF to the right. You can see that when modeled by the SHIF, the shape is superlinear and has lower uncertainty at the minimum, and the lower confidence interval is above 1 at 5 micrograms per meters cubed. The SHIF has some limitations. Each SHIF is fit to the entirety of the data, which means there's no local fitting at low levels where data are sparse. So this leads to difficulty in picking up the shape in areas where data are sparse. Further, the SHIF family may not cover all possible shapes of interest due to computational limitations. Next slide. Which leads us to the eSHIF, which is what was used by MAPLE. This is the extended SHIF, which uses a spline to fit the data rather than a sigmoidal function, just because splines are more flexible for controlling curvature. So in doing so, this puts weight on the full distribution of points rather than the areas where the majority of the points lie. And this helps to ensure that we are plotting the data at the tails more accurately. This means that the eSHIF maintains uncertainty at low concentrations. You can see also that the SHIF is superlinear, and that's the line that's in blue. And you can compare it to the spline that is in red. And we have also maintained the lower confidence interval here in the SHIF that was predicted by the spline. So it's worth noting that both the SHIF and the eSHIF can be directly implemented in air quality assessment research and benefits analysis, but do not fully characterize the concentration response function. Next slide. So to follow up on these findings, all of the teams explored associations at select lower concentrations. We wanted to know what the lowest concentration is at which we have evidence of a relationship between PM2.5 and mortality. So to do this, each project applied different criteria to retain persons or person years with exposures below certain levels, which were broadly aligned with air quality guidelines. ELAPSE restricted to persons who had exposures under 25, 20, 15, 12, and 10 micrograms per meters cubed, and Medicare and MAPLE restricted to those with 12 and under. Next slide. So here I am only presenting the results under 12 micrograms per meters cubed, as they're the most comparable between projects. And I've also included the person years, which you'll note are different for the smaller subpopulations. So you can see that there's a substantial increase in the Medicare cohort when limiting only to those with exposures under 12 micrograms per meters cubed. We go from 1.066 to 1.369. ELAPSE also found an increased risk, but with under 12 micrograms per meters cubed subpopulation, even though the hazard ratio goes up to 1.199 from 1.109, within ELAPSE, this is a relatively small subpopulation who have been exposed to under 12 micrograms per meters cubed. So you can see that the confidence interval is wide. And in MAPLE, the full cohort had a hazard ratio of 1.084, and we found a decreased risk for those who had exposures under 12 with a hazard ratio of 1.062, although the confidence intervals are overlapping. So we see that risk remains even for those who have only had low-level exposures. And in the case of ELAPSE and Medicare, the risk was actually increased for those who had been exposed to low levels. And it should be noted, of course, that there's high uncertainty in these subpopulations. Next slide. And so just one last function, which is a standard threshold model that we produced in the MAPLE project. This is a standard threshold model with thresholds from 2.5 to 10 micrograms per meters cubed by increments of 0.5. The linear models that we produced were weighted with an ensemble weighting function. So we weighted all the models by log likelihood. And you can see that most of the weight is in the range of 2.5 to 3.5, and the fit decreased as the threshold increased, as seen by the widening confidence interval. And the mean of the threshold was always above 1, and the lower confidence interval was above 1 at 3.5 micrograms per meters cubed. So this is just further evidence of a positive association at low levels. Next slide. So to summarize, there is evidence for the PM2.5 mortality association at low levels in all 3 studies. The MAPLE and ELAPSE concentration response functions were superlinear with the steepest slope at low levels and a plateau at high levels. This indicates that with increasing concentrations, the marginal changes in risk appear to decline. The Medicare function was near linear and indicated aggravated effects at all levels of PM2.5. So the main conclusion is that positive associations between PM2.5 and mortality are observed even at the lowest levels. Next slide. So moving forward, as Danielle mentioned, each team will try to do some harmonized work together. So we will all be using the eShift, using our administrative cohorts only, limiting to those who are age 65 plus. We are going to harmonize our covariates as best possible and use the same PM2.5 exposure, MAPLE version 2M, and we will all examine the same mortality classification. Next slide. That's it. Thanks.
Thanks so much, Tanya. I really appreciate your presentation, and I see a question or two about it, and we'll get to those again at the end of the session. Please remember to use the Q&A feature rather than the chat to track your questions so that we can keep track of those ourselves and make sure we get to all that we can. So now we'll move to our next speaker, who is Dr. Jay Chen. Jay's currently doing her postdoctoral research at Utrecht University. She's been working as the project manager of the ELAPSE study. Her research focuses on air pollution exposure assessment and air pollution epidemiology. She was also a member of the systematic review team working for the update of the WHO Global Air Quality Guidelines under the supervision of Dr. Hurai Hoek. Dr. Chen will present results from multi-pollutant analyses. And so I'll turn it over to you, Jay.
Thanks, Amy. So I hope you can see my slides.
Looks
so
great.
Yeah, thanks. Okay. So I'm going to present the results from multi-pollutant analysis in these 3 projects. Most air pollution epidemiological studies have focused on single pollutant research because it's easy to conduct and interpret. But in single pollutant models, it's not clear whether the observed association reflects the effect of the analyzed pollutant or if it acts as a surrogate for another pollutant possibly originating from the same source. And as the human body is exposed to multiple air pollutants simultaneously, the single pollutant models cannot characterize the complexity of the exposures and their health impacts. So the limitations of single pollutant models lead to the shift towards multi-pollutant approaches. One of the objectives of the multi-pollutant analysis is to estimate the independent effect of a single pollutant in the presence of other pollutants. Still, there are a number of challenges in interpreting results from multi-pollutant analysis. For example, in conventional linear regression models, the results will be highly unstable when incorporating 2 or more pollutants that are highly correlated. And the different measurement errors of different pollutants adds to the complexity of the interpretation, because the pollutant with the highest measurement error may show the most consistent associations in multi-pollutant analysis. And in most statistical models, pollutants are treated symmetrically, whereas in reality, air pollution can be divided into groups based on their emission sources, and some pollutants are precursors to others. And ideally, the inclusion of multi-pollutants in a statistical model should be supported by biologic mechanisms from other disciplines, such as toxicology. So in this presentation, I will share some experience in interpreting results from multi-pollutant analysis in these 3 projects. So I'll first start with the results from the MAPLE team. And the MAPLE investigated the associations between mortality and long-term exposure to PM2.5. And they also explored the sensitivity of the association to adjustment for ozone and OX. And OX here was used to approximate a combined oxidant capacity of ozone and NO2. So NO2 was not directly examined in the MAPLE study. This table shows the associations between PM2.5 and non-accidental mortality. And in single pollutant models, we can see that the effect, the associations between PM2.5 and mortality are similar in the stack contract cohort and in the CCHS. And in 2 pollutant models with adjustment for ozone, the association attenuated. And with adjustment for OX, the association between PM2.5 and mortality further attenuated. And in CCHS, the hazard ratio reduced to unity. But in these regular 2 pollutant models, the oxidant gases were included as linear terms. So the MAPLE team further performed stratified analysis to examine the association in the tertiles of the oxidant gases. So here we can see that in all the tertiles of ozone, we observed significantly positive association between PM2.5 and mortality. And the significantly positive association for PM2.5 was only limited to the highest tertile of OX. And if we look at the exposure surfaces of the oxidant gases, so this is ozone and this is OX, we can see a clear spatial variation in the exposure distributions. So the difference in the observed association in different in the tertiles of the oxidant gases could be explained by the spatially varying health impacts of PM2.5. So the MAPLE teams observed the strongest association between PM2.5 and mortality in areas with higher oxidant gases, and the observed impact of oxidant gases on associations for PM2.5 likely reflects the spatial variations in atmospheric processes or sources that can impact the toxicity of overall air pollution mixtures and not a direct biological impact. We'll continue with results from the ELAPSE study. So in ELAPSE, we investigated exposures to PM2.5, NO2, black carbon, and ozone. And we performed 2 pollutant linear models for all combinations of these 4 pollutants. This table shows the results from the pooled cohort. So here we can see that in single pollutant models, we observed significantly positive associations for non-accidental mortality with PM2.5, NO2, and black carbon. And in 2 pollutant models with adjustment for other pollutants, the association attenuated. But the associations remained significantly positive, except for the hazard ratio for black carbon adjusted for NO2. This is more difficult to interpret because both NO2 and black carbon reflects emission from traffic and other combustion sources. And the correlation between these two pollutants is high in this study. And this is also reflected by the substantially wider confidence interval compared to the single pollutant estimate. And for ozone, we observed a significantly negative association in single pollutant model. And in two pollutant models with adjustment for other pollutants, the association attenuated but remained statistically significant. And this table shows the results from 7 administrative cohorts by meta-analysis. So again, we observed significantly positive associations for non-accidental mortality with PM2.5, NO2, and black carbon. And with adjustment for other pollutants in two pollutant models, we observed attenuations in the association for PM2.5, and especially after adjustment for NO2, the hazard ratio for PM2.5 attenuated to unity. And for ozone, the associations remained robust in two pollutant models. And for black carbon, here the same story after adjustment for NO2. And for ozone, we observed a significantly negative association in the single pollutant model, and in two pollutant models, the associations attenuated and become insignificant. So in ELAPSE, we observed associations for non-accidental mortality, not only for PM2.5, but also for NO2. The hazard ratio for PM2.5 reduced with the adjustment for NO2 cannot be simply interpreted as an artifact related to multicollinearity, because the correlation between PM2.5 and NO2 is moderate, and the width of the confidence interval only modestly increased in two pollutant models compared to the single pollutant model. And the observed NO2 association may reflect the direct effect of NO2 or correlated combustion-related particles, such as ultrafine particles. And the reduction of the PM2.5 hazard ratio did not imply that the particles had not effect in our setting, because adjustment for NO2 also adjusted for particles from the sources shared with NO2, including motorized traffic and other fossil fuel combustion sources. And the differential measurement error may also explain the more robust associations observed for NO2 in pollutant models. So then in Medicare, they investigated long-term exposures to PM2.5, NO2, and ozone. And in an earlier publication, they reported results from two pollutant linear models with PM2.5 and ozone. And here we can see that in single pollutant models, the association with all-cause mortality are significantly positive for both PM2.5 and ozone. And in two pollutant model, with adjustment for the other pollutant, the association attenuated slightly for PM2.5. And the Harvard team also applied the GPS matching method to estimate the causal exposure response curve for air pollution and all-cause mortality. So here, the plots in the left panel shows the results from single pollutant models. And the plots in the right panel shows results from the multi-pollutant models adjusting for the other two pollutants as potential confounders. So here we can see that the exposure response curve for PM2.5 are almost linear. And after adjusting for other two pollutants, the causal impact of PM2.5 attenuated slightly. And the exposure response curve for NO2 are not linear. And adjusting for the other two pollutants elevated the health impact of NO2, because the Y scale is the scale of the Y-axis is different in these two plots. And for ozone, the increased hazard for ozone is observed for exposures higher than 45 ppb. And the exposure response curve is not sensitive to the adjustment for the other two pollutants. So in summary, the statistical methods applied and the pollutants examined are slightly different in the three projects. And the three projects consistently observed attenuated associations between PM2.5 and mortality after adjusting for other pollutants. But when interpreting the results, some factors should be taken into account. For example, the spatial variation of the exposure distributions and the emission sources of the pollutants and the correlations between pollutants. In terms of ongoing work, each team will apply multi-pollutant approaches that were applied previously by the other two teams. And the Harvard and the ELAPSE teams will additionally assess OX as an approximate for the combined oxidant capacity of ozone and NO2. And the Harvard and Maple teams will use the same PM2.5 and NO2 exposure surfaces. That's it. Thanks for listening.
Thanks so much, Jay. I really appreciate your presentation. And if you can go ahead and take your slides down. All right. So now we'll move on to commentary from my co-chair, Dr. Sferi Vidal, who is Emeritus Professor in the Department of Environmental and Occupational Health Sciences at University of Washington School of Public Health. His academic career was spent as a pulmonary physician and epidemiologist with a strong focus on air pollution health effects research. He served for many years on the EPA Clean Air Scientific Advisory Committee and on the HEI Review Committee. In the years before he retired from University of Washington in 2019, he worked part of each year in China, collaborating on air pollution research with investigators at the Chinese Research Academy of Environmental Sciences in Beijing. In addition to maintaining curtailed research activities, he chairs the HEI review panel of the Low Exposure Levels Research Program and is here to provide commentary and critique on these three studies. So Jay, I think we need you to pull off share screen right, and then Sferi should be good to go.
Thank you, Amy, and good morning to everyone. Is that
Sferi, are you able to put this in full screen mode?
I'm trying.
I
hold
saw
on. Okay, I got it.
Perfect.
There it is. All right. So I am going to make some selected comments about the studies that you've heard about. I have a list here of some observations that I made 2 years ago when I made a report from the review panel on this set of studies and some of the earlier work. And a lot of it still pertains. The first one is the issue of the plausibility of low level effects. And at that time, I made the point that our Bayesian priors were probably pretty low, and they've probably been nudged up a little bit here in the, or maybe perhaps more than a little bit in the ensuing 2 years. Should also understand that it's likely that there are fewer people that are susceptible to dying at low concentration. So we have, as you see in these three studies, lots and lots of data. But one of the issues that one is faced with lots of data, and it's a problem that's been faced by these investigators, is that the quality of the data sometimes deteriorates as the size of the data set increases. And other approaches have been needed in order to enhance the quality of the data. In these particular instances, the information on important covariates. You've been presented with a lot of new and advanced statistical methods applied in novel ways to this area. And then finally is the issue of causal modeling, which is rearing its head here. And I posed the question the last time whether this was in fact a revolution in the way we assess observational data, or is it just another way, another addition to our toolkit for handling confounding? And I'll circle back to several of these as I continue. You heard about the 3 studies. We're now in the final report stages that are in various stages of completion. Some are pretty much finished. And the 3 topics for today you've heard about: multi-pollutant modeling, control of confounding, including causal modeling, and then the issue of concentration response functions. I'm going to go through each of those 3 themes with respect to each study, and I'm going to try not to overlap with a lot that has been presented and simply extract some points that I think merit some attention. So first of all, I'm going to talk about the multi-pollutant modeling issue that you heard about. All of the, and start first of all with the MAPLE study in Canada. All of the studies have essentially used additional data on covariates, and have also predicted particle or pollutant concentrations at varying degrees of spatial resolution. So here in Canada, PM 2.5 was predicted at a 1 by 1 kilometer spatial resolution. Nitrogen dioxide at a 100 by 100 meter spatial resolution, and then ozone and oxidant pollution at initially at 21 by 21 kilometers, and in the more recent years at 10 kilometers. One of the marked with respect to multi-pollutant modeling in MAPLE was the marked attenuation of the PM 2.5 effect by both ozone and their oxidant metric, and then substantial effect modification by the oxidant gases, with the association essentially being strongest at the higher levels. One of the issues that this raises, and it's raised with all multi-pollutant modeling, is what it actually means to control for other pollutants. And the example that really rears its head with respect to ozone, as well as oxidant gases. And you heard the characterization of this association or this effect as not a direct biological impact of the oxidant gases themselves. That is, it's not, the argument there is that it's not reflecting actually the effect of ozone as a confounder of the PM association. And this is motivated in some part, to some degree at least, by what we know about the very tenuous link between ambient concentrations of ozone and exposure to ozone. In ELAPSE, you heard about the 2 large cohorts. The predictions in ELAPSE were at a fine spatial scale. So all of the pollutants were predicted at 100 by 100 meters. One thing to keep note of in ELAPSE is that very few of the countries that are included in these cohorts had what we would consider to be low concentrations. So for example, Norway in the administrative cohort, Stockholm and Sweden in the pooled cohort. Again, we see moderate attenuation of the PM association in one of the cohorts, and a very much more marked attenuation in the administrative cohort. You also heard that the NO2 association was not affected by inclusion of co-pollutants, and the issue of ozone as a negative effect, that is lower hazard ratios with increases in ozone, remained essentially negative with adjustment for co-pollutants. One of the issues to consider is this attenuation due to confounding by these co-pollutants? That is, can we take this as at face value? And I alluded to the issue earlier, is that It may not be an issue of confounding by co-pollutants and may reflect some of the things that were brought up in the presentation about differential measurement error and other issues, or the fact that they're actually reflecting something about atmospheric processes and aren't really measuring impacts of the pollutants themselves. The issue of ozone and the negative association is sort of an example of how these sorts of issues rear their head and make it difficult to interpret those types of effects. In the Medicare, you'll heard that one of the unique things about Medicare, it is limited to the older population. All of the 3 pollutants were estimated at the 1 by 1 kilometer scale, but they were averaged up. So they're averaged up to zip code. So the actual spatial resolution to which they are applied in the analysis is often quite a bit bigger than 1 by 1 kilometer. The PM 2.5 association was robust to ozone. And this is wrong. This was a result of the previous, what I saw for the previous work. In fact, when both of them are included, there is attenuation of the PM 2.5 association. The NO2 and ozone associations were largely unaffected with adjustment for PM 2.5. And in contrast to the other studies, the ozone effect is positive here, not negative. Issues that this brings up is are the spatial scales of the various pollutants, both in terms of the concentrations and in terms of the predictions, which we have to keep in mind in being able to make sense of these findings. The last point is moot at this point because of an error in the earlier slides. Now, confounding, I first start off with maple, and I'm being very methodical and mechanical here, and I'll try to blast through this relatively quickly. You heard that confounding was addressed by adding linear terms, linear covariates to the models, and making use of smaller cohorts that had more extensive data on covariates that were missing in the larger data sets in order to enable an indirect control for these sets of confounders. Importantly and reassuringly, there was a minimal impact of adjustment for these added variables. But one of the findings that you heard about in the MAPLE study was the fairly substantial variation in hazard ratios by region. One of the issues that we're then faced with, what does this mean? Is this residual confounding perhaps, or is it actually the case that there is variation in PM toxicity across Canada, depending on the pollutant mix? The issue of the effectiveness of the indirect control for missing confounders is an interesting one that we need to perhaps address, although all the investigators that have done this have done something to try to validate this approach to including this larger array of confounders. In ELAPSE, again, confounders were added to models in stages, as was done in the MAPLE study. And again, an ancillary data were used for additional confounders. In ELAPSE, we found that as the models became more elaborate, that has included more confounders, there were varied effects. In the administrative cohort, for example, 4 out of 7 had increases in the hazard ratio, and importantly, this included Norway, which was the country that most directly assessed the low concentration issue. And then with respect to adding external confounders, it was a little bit all over the map. Some increased, some decreased, and it was difficult to make a conclusion with respect to the impact of adding other covariates. Again, the issue of addressing the indirect adjustment is an interesting one. In the Medicare data set, again, also used ancillary data to provide data on missing confounders. And this is the only, as you heard, the only study of the 3 so far which used causal inference methods. The findings were that PM 2.5 effects were essentially insensitive to the traditional approach to controlling confounding, and that was largely also the case when results from the causal inference methods were shown. Although there was some attenuation of effects using the causal inference method at low concentrations, which is of more direct interest to us here. The issue of the causal modeling is controversial, and I'll come around to that just in a bit as to how we should interpret or weight them. There are advantages that we heard about in terms of relaxing a lot of issues and concerns about model specification and others, but there are assumptions that they make. And then there are they essentially require data on measured confounders if they don't handle unmeasured confounding, which can be an issue. And although the Harvard group did address the issue of unmeasured confounders in their work, which is using something called an E-value, which I won't go into further, but needs further assessment. Finally, with respect to concentration response functions, this is arguably of the three topics, the one that is most relevant to us here with respect to assessing the low concentration effects. So Canada, Maple, they, as you saw, have the lowest PM concentrations of all of the three studies. They used smoothing splines, which all of the groups did, but also introduced this SHIF, the shape constrained health impact function. And originally, this function was only used here in this data set. It has now been applied in ELAPSE as well. The last point is not correct. They did do restricted analyses at low concentrations, although perhaps not necessary given that Canada has such low concentrations to begin with. Findings were that you saw that there's a superlinear association, that is steeper at low concentrations, flattening out at higher concentrations. The issues here, you saw the concentration response functions using the smoothing splines were very wiggly. And that's a little puzzling. It's counterintuitive. The question arises whether with some automatic approach to selecting knots, location, and number, that the very, very large size of the data set somehow makes it sensitive to, makes it susceptible to showing a very wiggly concentration response function. The SHIF was an interesting approach. The panel has thought it's still early days with the SHIF. It hasn't been vetted thoroughly in the statistical or other communities. One of the puzzling issues that you saw in the presentation was that the confidence intervals were narrowest at the lowest concentrations and then fanned out, which is problematic. I mean, we don't normally see that, and it's in the sense that normally we see wider confidence intervals at low concentrations and high concentrations where there's less data. So how to interpret these confidence intervals is a challenge. And then there's the issue of flattening at the higher concentrations. These higher concentrations are not very high where it flattens, and many of you, of course, will recall that the sort of bread and butter work on air pollution and PM epidemiology was at these higher concentrations where we were seeing lots of associations. So the flattening is different. All right, and then concentration response functions in Europe are also a smoothing spline. They apply the SHIF later. They observe a superlinear association with flattening, and I've talked about the issue of flattening before. One issue unique to ELAPSE is you've got different countries, and the different countries have different concentrations. And so an issue to consider is how much of the shape of the concentration response function is just contributed by one country after the next as the concentrations march up. So for example, the part contributed at low concentration in the administrative data set is weighted by Norway. So is it something peculiar about Norway that weights that shape of the concentration response function? Finally, Medicare used also smoothing and restricted to low concentrations as an assessment of the low concentration effects. As opposed to the two other studies, their concentration response function was described as being pretty linear. That is not clearly a superlinear relationship, although you saw that the effect estimates, the hazard ratios at concentrations less than 12 were quite a bit larger than those less than 12. And so one wonders whether why that concentration response function doesn't really adequately reflect that observation. In summary then, with respect to multi-pollutant modeling, there was evidence for confounding by copollutants, but the issues of interpreting multi-pollutant models, even two pollutant models, are still with us, are problematic, and have not been resolved. That is still open to interpretation. We have the issue of different spatial scales, both of predictions and of the concentrations themselves. And then the issue of ozone has reared its head here as to how to interpret ozone effect estimates and also how to interpret effect modification by ozone. And that is still, I think, an unresolved issue. Confounding control, we saw there was some evidence that, or good evidence, that the associations persisted with a lot of control for confounding. We have now introduction of indirect methods to assist in the quality of the data, that is the data that we need for being comfortable that we've got adequate covariate control or control of confounders. We all want to conclude or exclude whether the associations are causal or not. And we want to do that using traditional approaches. We've always tried to do that. We say we're looking at associations, but our true interest is really in cause and effect. How do we weight findings from causal inference methods? Those of you who were around for the synthesizing evidence session, the HEI session a few weeks ago, you heard one end of the spectrum on how this is observed, this is characterized, which is basically that this is just one other way in which we can approach the issue of addressing confounding. As opposed to what has been argued, that we're now getting closer to a true experimental study as opposed to observational studies. That is, we're pretty much revolutionizing our approach to handling observational data. The jury is out as to which of these will hold the day, or is it going to be somewhere in between? And then finally, the issue of unmeasured confounders, which will require more deliberation. They've got a lot of confounders that are being assessed in these studies, and they've taken great steps in terms of enhancing these large data sets with other confounders. Finally, the concentration response function. There are three approaches to sort of addressing low concentration effects. One is, and you've heard them all, one is by restriction, that is just looking at effects at low concentrations only. Modeling the concentration response function, that is the shape, and then finally a threshold analysis where you compare models that assume a threshold with models that don't assume a threshold. Essentially, all the studies demonstrated, or the findings were, that there were low concentration associations. They were mostly largely superlinear or linear. We often hear the notion that this indicates that there's most potential for harm at low levels, which for many of us is a difficult pill to swallow. it may not be so difficult if you consider a couple of things. One is just sort of a thought example. Do we think that the difference between 5 milligrams per cubic meter of PM 2.5 and 15 is the same as that between 40 and 50? And, I think not. And that notion there may help in terms of understanding this apparent superlinear association. Toxicology has been of very little help in the area of low concentration effects. There is one notion in toxicology that is an interesting one, which is known as dose-dependent transitions, which basically means that the mechanisms of toxic or air pollutant effects changes by concentration. So one mechanism at a low concentration is perhaps saturated, and then another mechanism kicks in at higher concentrations. So there may be a way of trying to understand this from a mechanistic perspective. And the issue of shift needs to be more thoroughly assessed. And then finally, the third way of assessing low concentration effects has been threshold models. And essentially, we didn't see a lot of those results, but essentially the threshold models did not fit any better than the non-threshold models, arguing that the linear or superlinear characterization of the function is probably reasonable. With respect to the review panel, a couple of things. We're in the process of completing commentaries currently of the 3 studies. And then finally, we are going to pen an integrative synthesis of all 3 studies, assessing many of the themes that we've discussed here today. Thank you.
Thank you very much. At this point, I would like to invite all our panelists to turn on their cameras for the Q&A. And in addition, we'll welcome the PIs of the 3 studies, Drs. Brower, Brunekreef, and Dominici. I'll give them a minute all to pop on. And for those of you who still have questions, please do keep putting those in the Q&A, and we'll be watching that as we go on. All right, so I'll kick off with a question that was asked by Chad Bailey of the US EPA, and he directed it to Tanya, but really it's a question for all of our speakers. And the question is, what's the quality of exposure assessment at the lowest exposure levels? For example, less than 3.5 micrograms per cubic meter. More generally, how did the different research groups evaluate their exposure estimates at these low levels, and how similar were the methods for low-level exposure assessment across the 3 groups? And I'll let you start, Tanya.
Can I defer to Mike Brower on this one?
I can answer in terms of Maple. So we've actually done an evaluation where we've looked at, so we have an exposure model, and we've compared it to ground measurements, just as a way to evaluate. Not that ground measurements are necessarily always the best estimate of exposure. When we do that, however, we actually see smaller errors at the lower concentrations compared to errors at the higher concentrations. So we don't actually see a worsening of the relationship of our model estimates as we go to lower exposures. One of the other things that we did in Maple, as you heard, many of the studies are relying on a mix of methodologies, including satellite-based estimates. We did specific ground monitoring at locations of low concentrations in Canada to refine the relationship between satellite-based estimates and ground monitoring, also understanding the role of composition. So we really tried in Maple to tweak the model towards low concentrations. So I would say it's at least as appropriate. The approaches that we've used are at least as appropriate for low concentrations as they are for other concentrations. And the differences between the the studies. So there are differences. They're all using combinations of tools. Also, I would say the exposure levels and the distribution of exposures are quite different across the different cohorts. So it may not be appropriate to do exactly the same thing. And also where the cohorts are, urban, rural, et cetera, national, restricted, to specific cities. In the ongoing work and the harmonized analysis, we are going to be applying the same exposure estimates to all of the cohorts. So that will be one way to sort of evaluate, I guess, the sensitivity to exposure. But having said that, again, I think it's really important to remember that the cohorts are different. And where people are and the characteristics of the cohorts are different. So this is never going to be a perfect experiment of the effect of exposure models. And others can join in, Bert, Francesca.
I can jump in. So like Mike, so we actually compared our estimates from our PM prediction model to actually EPA monitors, and we see actually lower error in the low concentrations than the higher concentrations.
Yeah, we haven't made that assessment formally. If I remember correctly, we've published our exposure work a while ago. And we've extensively validated against ground level monitoring with a whole lot validation techniques, etc. I don't think we see much difference between the different cohorts studied at different levels of exposure, for example. But a strictly formal assessment of the validity at different bins of the concentration range, I don't think we've done that.
Amy, I think there was a couple of questions addressing the issue of measurement error as it relates to the very important issue of the shape of the concentration response function, one by David Bessard and Leanne Shepard as well. So David Bessard said one of the arguments heard about the shape of the dose response curves is that epidemiology can have errors in exposure measurements that might yield a more linear dose response relationship between the imperfect estimates of exposure and the data on health responses, even if the health effect were highly nonlinear, or even if there were a threshold. For PM, there might be an argument that even if the threshold for responses to individual chemicals that are part of PM, the multiple chemical specific threshold might result in a smooth response as a mixture. So he would be interested to hear thoughts about how the work informs whether either of these occurs in the EPI studies of PM, that is the measurement error resulting in a linear relationship when their fact is a threshold, and also perhaps the issue of a multi-pollutant effect or contribution of PM that results in linearization of the response. Dr. Shepard, Leanne Shepard, said she's interested in a more full discussion of the rationale for differential measurement error in these studies.
So maybe I can start and comment on some of the work that we've been doing on measurement error, which we have been doing quite a bit on it. So we did apply a regression calibration approach to try to adjust for the measurement error. Essentially, the regression calibration model was fit on the EPA monitors, and we were able to then predict, quote, true concentrations for the entire US. Well, for New England was in our publication, and now we've expanded this to the entire US as part of ongoing work. The estimates so far have been robust to the adjustment, which is good and still statistically significant. And then we have a whole, actually, another grant on kind of uncertainty and trying to potentially ensemble different exposure models to see if that can kind of help in terms of get even more robust estimates for the exposure. And then we do have ongoing work and in a couple of areas, both from a Bayesian modeling perspective, to really try to propagate actually the uncertainty that we do see all the way through from the exposure estimate all the way through into the outcome model. So it's something that has definitely been on our mind, and research that we are excited about and is kind of ongoing, and I think is important, and hopefully we'll have more publications soon. So I don't know, Francesca, if you want to add to that or before we.
No, I think
Okay.
I think you said it all. Thank you, Danielle.
The difficult question is what the gold standard is to assess measurement error in these studies. And we've done a couple of projects in the past using personal monitoring in small groups, because you can't do personal monitoring in large groups, to try to establish the correlation between the estimates that we use in the EPI for the outdoor studies and the personal monitoring. But is for the spatial contrasts, those correlations tend to be not all that high because the spatial contrasts are not all that high. So small errors in the measurement of the gold standard can easily produce low correlations between the data you use in the EPI and the personal monitoring results in the panel studies that we did. Together with the Harvard group, we did do some regression calibrations, but especially when these correlations are small, you can easily find, 5-fold inflations of the regression coefficients or the effect estimates after adjusting for measurement error that way. We've been very hesitant to see that as a better assessment, a better estimate than the one that we get from using the outdoor concentrations alone.
I'll just add, we've done a couple things also to sort of look at this maybe a little bit differently. One of the things we did was looked at different basically spatial resolutions of our exposure model. So you can imagine, for example, I think people would like to think that the more precise spatial resolution, the better, but people are actually mobile. So we looked, for example, at 1 kilometer, 10 kilometer, maybe to account for mobility. We also did different sizes for the age of the population. So, for example, thinking that older individuals may be less mobile than younger, that really didn't have much of an effect at all. In all cases, the more refined exposure seemed to be basically give us better models and higher exposure estimates, as you might expect. But actually, the main point that I'd like to bring up when people think about exposure measurement error, they're always thinking spatial. There's also a temporal error. And one of the things, just to highlight, certainly in MAPLE, and apologies to the other studies, I can't remember exactly what was done. We actually have annual residential histories for every individual in the cohort. So we're adjusting for changes in address over time as people are being followed up in the cohort. So that, in my view, is actually a greater source of exposure measurement error than the spatial aspects or sort of the personal monitoring, because that kind of thing, you'd have to actually assume that this is sort of differential ambient to personal relationships across individuals, and I think that's sometimes a tough argument to sell.
All right, so we've gotten a lot of questions about statistical analysis, which makes me very happy. So you can see some books behind me. So I wanted to bring up the most popular topic, which seems to be splines. So we've received a number of questions about them, ranging from the basic definition of splines to how the modeling approaches themselves, address the possibility of overfitting, and the type of penalty for not selection. So just kind of as a broad overview, splines are flexible smoothers, and they're an attempt to model complex functions without forcing weird relationships in the tails that you might get from using a really high order polynomial. It's important to keep in mind that if that a straight line fit with a slope of 0 is possible using a spline. So if there's no association, we would expect a spline to reflect that, though a detailed discussion of splines is unfortunately beyond the scope today. But I would like to ask the researchers to talk more about how they approach the possibility of overfitting, how they addressed model adequacy and model fit, and how they made choices among the possible dose response parameterizations. Who'd like to start? Okay, I'll pick on Francesca.
I can take this.
Take it to Danielle, but yeah.
I can take it as to some extent. So I think it's a really good question. I think it's really challenging, and we have been actually diving more and more into the exposure response modeling in recent months. And especially as a side note, we've been doing some analysis by subgroups, which has been really interesting. But it kind of raised, it seems like modeling choices may be even more sensitive when you start looking at certain subpopulations, say different racial groups. So it's definitely something that we've been thinking a lot about recently. I have just one comment on related to kind of the multi-pollutant aspect of this modeling. So for us, like we ended up including the other pollutants as actually terms in our generalized propensity score model. So they're not actually in the outcome model, which I think might help with the overfitting. So I just wanted to point that out, but I think it's challenging. The more personally, the more I dive into it, the more challenging I realize the modeling is.
So if I could also just quickly comment, I think we also been paying extremely amount of attention of thinking about causal modeling in the exposure response function.
Yeah.
So actually thinking about to match individuals at different level of exposure. And so I also want to comment a little bit about, some of the statement as Vera made. I mean, in terms of whether causal inference is a revolution. Well, I wanted to point it out that causal inference has been around for over 25 years, and there have been over 45 books, as much as I know, that have been reading on causal inference methods. So I do think that, the inability to implement some of these causal inference methods should not given license to criticize. There has been an enormous group of statisticians that have been spending the last 20 years of how to approximate an observational study into a randomized trial. Are they perfect? Not. Are they better? I think yes. And also I wanted to correct about a statement which is, just basically wrong, that causal inference method cannot just for a measure confounding. I think that causal inference method and some of the methods that we have done in peer reviewed and many of other colleagues do adjust for a measure confounding, including a recent publication of George Worth, which used difference and difference estimation. So I do think I'm not the strongest advocate of causal inference methods, but I do think that we need to recognize the level of sophistication and modernize, and I think it's time for environmental epidemiology to embrace the fact that these methods have been around for a very long time. And so I think that in terms of addressing the question of causal modeling and exposure response function, with causal modeling and adequacy of modeling assumption, we can actually assess whether or not the measure confounder are indeed balanced at different level of exposure. And that I think is, as it been chosen, a much more robust approach to adjust for measure confounding in the context of flexible exposure response.
Good, thank you. I wanted to change gears just a bit and use a question from Stephanie London to address this issue. And her main concern is the issue of still adequacy for control of confounding, and specifically focusing on smoking, even though there are the ancillary data sets that are used to supplement confounder control in the larger cohorts using the indirect adjustment methods. Her concern is that the smoking adjustment is still relatively crude, and that there is still some substantial residual confounding, or potential for substantial residual confounding, in this case, for example, from cigarette smoking. So I guess I would ask maybe perhaps each of the cohorts to sort of address the issue of the adequacy of say, control for smoking, which is such an important predictor of mortality.
So first of all, can I just quickly reply? I mean, let's also keep in mind, again, I think there is really a misunderstanding here of what is a confounder, and the distinction between what is a confounder and what is the predictor of the outcome. And I think after 20 years, it seems there is still confusion on that. So smoking is indeed a very strong risk factor for mortality. But the fact that smoking is a confounder has to be related to inhalation of outdoor exposure to pollution. And so far, data have not provided a strong evidence that there is a relationship that, between smoking and exposure to pollution. So I am actually quite surprised that after all so long, including making comments about causal inference, there is still misunderstanding of what is a what is a confounder. Having said that, I think what we have done is we have used data from the Medicare current beneficiary survey that use individual level smoking and to assess whether or not smoking is a confounder. So whether or not there is a strong evidence that people that are smokers live in more polluted area. And that is actually not clear, including doing full analysis that adjust for smoking. And so that's, I think, also why I think there is still a lot of confusion and misunderstanding of what are really the important issues.
Good, thank you.
A few remarks on that as well, I think. The relationship between smoking and air pollution varies from time in time, and it varies from place to place. So you can't just say that if you have not adequately adjusted for smoking that you have a problem in the sense that you're overestimating the air pollution effects. And I think, as was remarked by some today, seeing the effects of the indirect adjustments going in different directions in the 6 ELAPSE cohorts actually speaks to that, I think. If I remember correctly, Mike, in the Canadian study, you also see, effect estimates moving from null or even negative to positive after adjustment for more and more potential confounders, which is opposite to what most people think it will happen if you do adjustment for potential confounders. In ESCAPE, we actually, which is now a while ago, we actually did see that adjustment for smoking did make a difference. So it was, for most of the endpoints, it was very important to look at that. But we also noted that it's much more important when you look at lung cancer than to most of the other endpoints, because smoking is such a big risk factor for lung cancer. So there you may go wrong more easily. And that's why we, in ESCAPE, for example, we restricted our analysis to cohorts which really had very detailed information on smoking habits when we addressed lung cancer. And finally, most of these cohorts are looking at smoking also as an effect modifier. And in non-smokers, smoking is hard or impossible to be a confounder. So, focusing on what happens in non-smokers, lifelong non-smokers, is an important argument. And that's the majority of the population in most places that I know of. An important argument to look at when you run into discussions about whether or not these associations are to a large extent explained by smoking. These are just a few observations which I think are important.
That's excellent. And I'm aware that our time has almost gone. Just like at a regular in-person meeting, we do have some time maybe for one more question and push the schedule a little bit. And so I wanted to pick up on David Spink's question about thresholds. And so in particular, he said, based on the results, it seems like maybe there's a no effect threshold in the range of 2 to 3 micrograms per cubic meters for PM 2.5, but no threshold for NO2. So can people comment on that?
I think in the threshold model that I showed, we had the most, the strongest evidence in 2.5 to 3.5. So I can't speak to the NO2, but I think also in the Canadian study, most people have low levels of exposure, but in ELAPSE, there aren't people with, or a lot of people with 2.5 to 3.5. So it's not necessarily easy to be exploring that in certain cohorts, but I can't, if anybody else wants to talk about NO2, feel free.
I think some of the graphs shown from the Harvard team suggest that thresholds for NO2 and not for PM, but that's certainly not what we're seeing in ELAPSE. Of course, you can't make a statement on anything that's lower than the lowest observed concentrations, and preferably a little bit above that. The threshold models that we ran consistently showed that whenever you put in a threshold, the fit of the model is worse than when you do not put in a threshold for what it's worse. But that's an observation that we had. And the simple censoring approach that the subset approach that we did was also not supporting thresholds anywhere near the levels of air quality guidelines and standards. And that's the important policy implication, I think. If we can convince ourselves that these associations persist well below current guidelines and standards, then we have an important policy message, regardless of whether there is a threshold at 1 or 2 or 3 micrograms per meter cube, because that's not a very relevant policy question for the next 25 years, I guess.
The only thing I'll add, I have nothing more to add on PM 2.5. I agree completely with the other comments. And I don't really think we've looked at this at all for NO2, but for ozone, we actually do see evidence. We haven't looked at it formally, but we do see sort of evidence of a threshold where there is a range of concentrations where we do see no effect, and then the risk starts to increase at higher concentrations. That, however, I'll point out again, that could be more where ozone is high rather than actually the effect of ozone. So it may be reflecting something else, either about the cohorts or the multi-pollutant mixture.
Super quick, I just want to say this is a really important question. We are doing additional work to try to quantify evidence of threshold and quantify evidence of where the threshold is going to be in the Medicare study, doing a Bayesian version of doing a Bayesian estimates of the derivative of the exposure response curve. So just because of that, this is such an important topic.
That's great to hear. And it sounds like even though we're coming to the end of our session and of our studies, there's still a lot of work for people to do. We really appreciate our speakers and their work on this important topic. And now I will turn things back over to Eliane van Vliet.
Thanks very much, Amy. Okay, I'm not able to share the screen. In any case, in closing, we want to thank the speakers and chairs for this thought-provoking session on health effects from exposures to low levels of air pollution. And please visit our website to find recordings and slides of this webinar and all our previous in the series. And also, to help improve our webinars, we'd be grateful if you could complete the post-webinar survey, which will be emailed to you tomorrow. We want to thank all the attendees from all over the world for joining us today for our final webinar in our series. And we really hope you'll join us next April in Washington, D.C. For our annual conference. And you can find more information on our website. Thank you again, and we wish you all good health.